Thank you very much for everyone for joining. I know that it is a really special webinar, especially with World Diabetes Day being on Friday as well. So for those of you who don't know me, my name's Laura and I'm the Health and Wellness Manager here at Seven. So this Global Day is a really important reminder to the impact that diabetes has on us as individuals, but also our families and our community. So it has a vital role of awareness and prevention is our main aim today, to educate in the importance of, our health and our outcomes when it comes to moving forward to have a healthier, happier lifestyle. So now, while I'd be first to say I'm definitely not an expert in this field in particular, this is why we have brought in Ali, who is amazingly educated in this field. He is the founder of GluCare Health, which is a clinic here in the UAE and a clinic that I would very personally recommend as a nurse myself to my family and friends, and also all of yourselves. I'm really looking forward to hearing more about this session. But keep in mind, if you do have any questions throughout, any that are more relevant to yourself, please feel free to drop those questions in the chat box, or you can wait until the end and unmute yourself and ask those questions as well. So Ali, why you exited and then obviously came back, I did do a little introduction of myself. Yeah. I have met you, but also the wonderful clinic that you're part of, which I said as a nurse, definitely somewhere that I would recommend for my family itself. That's very much the point of these sessions. And I think that anybody who's been in the UAE for long enough, it's about really partnering with people and providers that you trust. And definitely, Ali and your team, after getting to know them very well over the last couple of months, I felt that this session, being World Diabetes Day on Friday, is very relevant for any education. And I know you are very educated and knowledgeable in this space. So that's why I would love for you to take the floor and just any education, any tips, any advice in regards to prevention, healthier lifestyle, so we can help and prevent this.
Yeah, happy to. And also, happy to make this a bit conversational as well, so that people can ask questions whenever they feel the need. I'll give a little bit of background, because I think that's important in terms of understanding what we built and why we built it. I've been in healthcare for a really long time. I previously built a hospital group here in the UAE called Amana Healthcare. It was a very different business. It took care of a lot of kids with a lot of congenital genetic abnormalities. It was kind of like a giant ICU. Not a lot of tech in that business. It was a little bit like Hotel California. Someone would check in, they'd never check out. And we built that to be a meaningful part of the ecosystem, save the government an incredible amount of money by bringing a lot of patients back home from abroad. And that was really impactful on a hyper localized level. After selling that business, for the next adventure, I thought, gosh, it would be much more interesting for me to build a business that has potentially global impact and tackling something that affects people far beyond our local home market, but to use the advantages that we have in the UAE to really drive innovation and a technology agenda that may not be possible in my home country, the United States, as easily. So, GluCare started as kind of a thought experiment. Back in 2019, we looked at all of the possible burdens of healthcare that exist. And you guys probably know this already. We live in a region that is probably one of the most obese and diabetic populations on Earth. The United States is not far behind, but most countries have a growing problem with metabolic disease, and diabetes is the most severe form of metabolic dysfunction that is increasingly consuming more and more national resources. Part of the reason your insurance premiums keep going up every year is because more of us are getting sicker and for longer, and it's costing an incredible amount of money. The challenge is that it's not getting better, right? And there's an insight that I share quite often, which is, over the last 50 years, all aspects of healthcare have gotten better. Our technology has gotten better, our drugs have gotten better, our research has gotten better, our hospitals have gotten better, our access to healthcare has gotten better because more and more people have access to health insurance. Regulations have gotten better. So if you think about the ingredients and the inputs that make up our healthcare systems, and this is worldwide, things have on trend gotten better, not worse. Yet here we are, fatter and more diabetic than we've ever been in human history. And that begs the question, why is that? Why are we so bad at managing chronic disease? And part of the answer, sad to say, lies in the way we structure health insurance and the way that we consume healthcare. And it's great to see that your insurance broker and your insurance company is taking steps to challenge that notion. But the way that we've historically treated healthcare is episodic. You go to the hospital when you're sick and when you have a problem, but that's already kind of too late. And I'll take myself as an example. When I started GluCare, I was almost obese. I was probably about, 18 kilos heavier than I am today. I was pre-diabetic. I had a fatty liver. I had high cholesterol, high uric acid. For the first time in my life, when I was in medical school, I was, extremely fit. But life gets in the way. You start working, you start traveling, you have kids, and you get injured, as I did. I had 2 major surgeries, and next thing I knew, I woke up in my mid 40s, actually my early 40s, and I was on a really bad trajectory. And so when I opened GluCare, I was one of the first patients. I turned myself from a 92 kilo guy to now 64. Well, sorry, no, about 70, sorry, about 70 kilos, 164 pounds, and reversed everything, and that journey taught me a lot about the burden of the disease, how hard it is. I'll give you the punchline now. Ozempic and Mounjaro are not going to solve diabetes overnight. And, a lot of people that might be on these medications, might be experiencing great success short term with weight loss, but in the long term, anyone who's using these medications in an unstructured and unsupervised way is actually creating bigger problems for themselves down the road. A lot of muscle mass loss with the unstructured use of these medications, and 5 years from now, we'll be dealing with a new problem, which is called sarcopenia, which is the loss of lean muscle mass over time. But sorry, I'll dive into that later because I know a lot of you guys will be interested in the whole GLP space. But kind of getting back to the background is, when you think about the future of medicine and what it should be, it shouldn't be episodic, where you get sick and you go to the hospital and that's the first interaction you have with the healthcare system. If you had asked my insurance company in 2019, is Ali a healthy guy? And I should probably use an image aid. Give me 1 second. I'll pull up a photo for you guys so you can visualize just what I'm talking about. And maybe some of you may have seen this on LinkedIn already. So that was me when I launched GluCare. Had you asked my insurance company, is that guy healthy? They would have said, absolutely. He's never had a healthcare claim. He doesn't go to the doctor. He doesn't cost us anything. He must be the pinnacle of health, the example of health. And I was so far from it. I was literally on the path to becoming my grandfather, who died of complications related to type 2 diabetes. So our insurance companies and even our employers don't actually really know what our health status is until it's too late, until we're so sick that we actually interact with a doctor or a hospital because we have chest pain, because we're massively overweight, because we can't breathe, because we can't run, because we've been injured, because our joints are failing, because we're carrying too much weight around. So by the time those things happen, which are burdensome enough that makes you pick up the phone and make an appointment with the hospital or the doctor, it's too late. Those risk factors started a decade earlier, like in my case. And had you asked my insurance company, they say, yeah, Ali's super healthy, but I wasn't. And so that's the major challenge that we have with the way that we structure our healthcare system and how we consume healthcare. But things are changing. And if you think about how medicine should be in the future, the underlying premise that we believe strongly in is that medicine is continuous. It's there when you wake up in the morning. It's there when you go to sleep. It's when you take a bite of food. It's there when you go for a walk. It's there when you work out. It's there when you're with your family enjoying a special event. Healthcare should be with you all the time. Why isn't it with you? Because it doesn't see it. Your doctor only sees you when you're right in front of that doctor's face. And you'll probably resonate with this comment. Even if you're in front of your doctor's face, the doctor's probably over here looking at a computer screen, typing into, the electronic medical record, not even looking at you, despite the fact that you're in the same room together. So even the physical experience that we've all had with healthcare is horrible. It's been designed as a machine. It's been designed as a volume-driven play to get as many patients through as possible, and it doesn't work. That's why we're all so horribly metabolically dysfunctional. Now, how do you change that? Well, first and foremost, you need visibility on daily life. And 10 years ago, that wasn't possible. You started to have wearable devices that were popping up, like the Fitbit, like the early Jawbone, that were starting to use optical sensing on the body to do things like step count. And I saw those signals back then. And I thought, well, this is interesting because if these devices get better and better, that becomes a continuous source of data. What can we do with that? And by the time we started GluCare, devices were starting to get really quite good, where the data that they were producing could be used in a clinical setting. We soon became the first global clinical partners for the Aura Ring. We use continuous glucose monitors quite heavily. I don't know if I have one here I can show you guys, but you've probably seen people wear it. It looks like a small coin, and that little device measures your blood sugar every 5 minutes. And so there's starting to be this environment where you can continuously pull data and track it and use it to deliver care in a meaningful way to your patients when they're not in front of you. So we started GluCare as what I call a hybrid healthcare model. And it's probably one of the first examples in the world of truly hybrid healthcare, where we have all of the stuff that happens normally, physically, in a hospital. In fact, we have a lot of stuff that doesn't happen in a hospital because there's a lot of new modalities and technologies that we were among the first in the world to launch. And I'll get into that a little bit later. But we also have an engineering team, like you would see in Silicon Valley. And they're constantly building tech for us and AI and apps and protocols. We built our own electronic medical record. Why? Because it didn't exist in the way that we needed it to exist. I want to be able to pull your lab test data, your imaging data, your sleep data, your stress data, how much you've walked, how stressed you've been, your food log. I want to give you surveys. I want to have you have the capability to chat with my care team. All of this technology in one place. Now, it existed in various disorganized array of different apps and functions, but no one had ever built it in one place. And so that was the heavy lift that we needed to do back in 2019, 2020. We started building all of that. My head of engineering was, until I stole him, the head of engineering for a $13 billion tech company in San Francisco called Hims and Hers. It's a consumer health tech company. And so we're very serious about the technology that we're building, and we're capturing more data about our patients than ever before. Now, because we're a medical facility, all of that data is covered under the strictest privacy laws because there is a degree of burden on healthcare providers to adhere to patient privacy that you don't find on tech companies and on Facebook and on Instagram. And so by virtue of us collecting this data, we keep it secure, we follow HIPAA, we follow all the local UAE regulations under the strictest data privacy laws for patients, which are, like I said, among the most strict. And so what ends up happening is that we have a platform that allows us to engage with you in person, driven by a human interaction. We don't believe AI in any near future scenario is going to replace the human. The human is just too important, right? When was the last time you relied on an AI to make an important decision in life? You don't. You rely on your wife, your brother, your mother, your friend. That's who you get advice from. That's who you really listen to. AI is useful, and we're all using ChatGPT to, respond to emails and so on. But when it becomes to a really important life decision, especially when it involves your health, it's not enough. And we don't believe that is the direction that we should take. Um, so let me kind of frame this in the way that what your experience might have been in other clinics and what experience you will have at a clinic like ours. If you're diabetic, and I don't know if anyone on the call is, but you'll resonate with this. If you're diabetic, you're spending a lot of your life managing your own disease. It's hard, especially if you're a poorly controlled diabetic. So once you're diabetic, you've got to see the doctor once every 3 months, according to clinical guidelines. You've got to get a blood test once every 3 months. This is the basic sort of minimum level guidelines. If you're poorly controlled, it's even more important. If you're really well controlled, you can probably stretch that out a bit. But you're already going once every 3 months to the doctor. Now, what does that look like? First, you go to the doctor. The doctor says, how are things going? Okay, I need to get an update on your blood tests. Then the doctor sends you somewhere to get your bloods done. They might take the bloods in the clinic themselves, or you might have to go somewhere else. So that's a second visit. Then you're going to wait a couple of days for those blood tests to come back. Somebody sends you an email, maybe it's a PDF, maybe the doctor calls you because they also got the PDF and they say, hey, look, I've looked at your labs. You know, your numbers have changed a bit. I'm going to change the dose of your medication. I need you to go to the pharmacy, pick up some new medications. That's a third visit now. Oh, and by the way, your liver enzymes are high. I need you to go to the diagnostic facility to do a liver scan. That's a fourth visit. You go to the liver scan, it comes back, the results after a couple of days, doctor calls you again. Hey, as I suspected, you know, your liver enzymes are high. You've got a fatty liver. I need you to come back in. I need you to see you again. Or I need you to go see a hepatologist. Oh, by the way, also, it's time for you to go to see your annual cardiologist visit. I need you to go see a cardiologist. Then the cardiologist sees you and says, you know, you've got a risk of heart disease. I actually need you to do a calcium score of your heart. You need to go to an imaging center, do a CT scan of your heart. We're up to a half a dozen visits already, and we've barely tackled any of your risk. We haven't done anything yet. And that gets worse if you've got kidney problems, if you've got foot problems, if you've got diabetic blindness related problems. You know, diabetes is a multi-system issue because high blood sugar is like, think about it this way. When you've got chronically high blood sugar, it's like tiny razor blades in your blood vessels, just floating around, damaging everything. That's why we call Alzheimer's and dementia type 3 diabetes, because it's all the vascular damage that's happening in the brain over time. So every single system of the body gets affected by high blood sugar. And the problem is it's really slow. It takes a really long time. So you don't notice it. It just happens. And then one day you wake up, you've got a super high risk of cardiovascular adverse events, heart attack, and so on. You've got high risk of dementia. And by then it's kind of too late. We should not, absolutely should not wait until that time. And so I'm sure you all have a headache now, just describing that journey. And that's a very common journey. 20% of the population.
I was just going to say, there is absolutely no way that I can make any excuse for not going for and doing like a half an hour walk tomorrow or, you know, this afternoon. Yeah. I think when you think about that and the time and the energy and that half an hour walk or half an hour run, I'm going to take that any day.
Yeah. I mean, there are a lot of easy things that we can do that are accessible and available to manage risk, but you know, it's an invisible risk, and the problem is with invisible risk, it's hard to feel it, it's hard to know that it's there, and therefore the motivation to do something about it is hard to grab. But once it's manifested, you're living with it forever. And you know, 20% of the population at least is diabetic already. And another 20-25% of the population is pre-diabetic. So that's almost half of the population of the UAE. Half of the people on this call, statistically speaking, are dealing with underlying metabolic risk that needs to be managed. If you layer on overweight and obesity on top of that, you're at 70% of the population. So this is not like something that happens to like some, you know, second cousin. This is something that's going to happen to most of you on this call at some point of your life, if not already. But it's invisible. Good news is there's a lot we can do easily to help manage that risk and to fix it. Now, you can already feel the burden of the disease. And so one of the things that we set out doing was to lighten that burden. And the way that we did that is we completely re-engineered the physical experience. Laura's been to the clinic. I don't know if any of you have. But if you come to GluCare, it's like magic. We've built everything in one place so that our patients don't have to bounce around. We have our own lab in the basement. I don't send out your blood tests. I do it in 30 minutes instead of 3 days. We do it on the spot. As soon as we take your blood, we run the blood. We do a whole series of AI-powered diagnostics, many of which don't replace a physician, but replace the need to go to a physician for the diagnostic. So we'll do an AI-powered liver scan, an AI-powered thyroid scan, an AI-powered assessment of your airway to detect sleep apnea, powered scan for diabetic retinopathy. And the same scan will send it to a second AI company, which it calculates, and this is crazy, we're the first in the world to do this. We have an AI that will calculate your cardiac risk from a scan of your eye, because your eye, you can actually see the vasculature and the nerves. We do an EKG, a brachial index score, a pseudoscan, a whole array of initial diagnostics just to figure out what is your underlying risk at a full body level. All of this is covered by your insurance. By the way, a fraction of this is what they try to sell you at longevity clinics for cash. Don't ever fall for that. Most of this stuff, the stuff that's clinically useful, where there's clinical evidence for it, a medical facility like ours with a good relationship with insurers that know that we're not doing extra stuff, we do the stuff that we need to do to manage your risk, most of the time it gets covered. And the good news for you guys is that we're in network with your insurance company. We work very closely with 7 brokers. And so, we're very actively partnered with them to help manage this kind of risk. And so all this stuff, obviously I think there's usually a small copay, but all this stuff, which is an immense amount of value, gets covered by your insurance policy. And you do it once. You do it once and you get this baseline. It happens in a single visit. I had a friend of mine who's the head of AI at Databricks in the US. This guy, has anything accessible to him that he possibly could want. And when I ran him through the journey, he said, gosh, Ali, what you guys did in an hour would have taken me 6 to 8 weeks of chasing and coordination in the US to get done. But because we built it in one place with one seamless journey, it saves an incredible amount of time and energy. So you'll go through first the bloods and all of those diagnostics before you see a physician. You'll go because we ask you to come in fasting. As soon as you're done with all that, you go to the cafe. Everything's complimentary. Break your fast with a smoothie or a coffee or whatever you want. And by the time you're done with your espresso, the doctor's ready to see you. All of your data is already on the screen in the doctor's office on the same day. So you sit with the doctor. It's not a 10-minute visit with the doctor distracted by a laptop because we got rid of the desk. There's no desk in the doctor's office. The doctor's there to talk to you like a human, like a partner. And with your data on the screen, you go through your data together. You identify where the risks are. And the doctor is now trying to understand your cultural limitations, your background, because risk is part of the story, but the patient's culture and context is a bigger part. If I've got someone who's diabetic, who's from Indian origin versus someone who's diabetic, who's Russian, the advice that I might give in terms of lifestyle and behavior change will be radically different. So it's really important for that human element to be understood, because that partnership between you and your doctor is about setting goals together. The doctor will ask you, what's your goal? Do you want to reverse your prediabetes or manage your weight or manage your cholesterol levels? On what time frame? How aggressively do you want to do it? How much reliance do you want to have on medication versus other factors? And so that's when the conversation begins. And now you're really engaged, because for the first time in your life, you actually understand your disease. You understand the risk and why the risk is there. But more importantly, you have a sense of agency and ownership because you know what the different tools are that can help manage that risk, because the doctor's going to start walking through those tools. Now, we're not purists. I kind of hate people who walk around categorizing themselves and siloing themselves. Some people say I'm a naturopath. Some people say I'm a functional medicine doctor. Some people say I only follow Chinese medicine, Western medicine, Northern medicine, Southern medicine. That's all hand waving. The only thing that matters is, does the evidence support the approach? If you hear someone say, oh God, pharma is bad, big pharma, we should only use, food and plants and natural means to cure ourselves. That's naive. There's clinical evidence that should support certain interventions. Food is medicine. There's clinical evidence for it. There are certain drugs and medications that are also backed by clinical science that work. So our approach is not to silo ourselves into the functional medicine category or the naturopath category. We use whatever works for our patients, and we help our patients figure out what works best for them. So one patient might say, hey, I I know that I'm not going to be able to manage my food on my own. I'm going to need the support of Manjaro. And on Manjaro, then I can really start building the other building blocks. And somebody else might say, hey, I've got the willpower of an ox. I can do it. And I'd rather try to do it without the medications. And that's also fine. It comes down at an individual patient level, right? And so that's just the beginning now of the journey. After the doctor's visit, we do a whole bunch of things that actually the insurance companies don't pay for. But for now, we do them on a complimentary basis for our patients. We're starting to create a membership program for some of these services. But we have, dietitians, nutritionists, diabetes educators. I have a master's in sports science on my team to teach people how to train. Because if somebody walks in who's obese or pre-diabetic and you say, hey, you got to go to the gym, it's really, really important to protect your muscle mass. 100% of the time, they're not going to go to the gym because it's hard. It's not that they're lazy. It's that, it's intimidating to go to gyms with all these muscly people on their Instagram taking photos of themselves. You've got body shame issues when you're overweight. You're worried about safety and working out effectively. So there's a lot of friction in getting people to change some of those habits. So if you come into our new clinic, you'll be surprised to see that we have a gym in the clinic. It's one of those things we don't get paid for, but we do it because it's the right thing to do for our patients. So we have a gym there. It's a teaching gym where our sports scientist works with our patients to teach them how to train so they can graduate into habits that they can own and drive forward independently from us. And so there's a lot of elements that follow what would have ordinarily been the end of your experience. You go to the hospital to see your doctor, you do your labs and get the medications, and that's it. You're done until the next year or whatever. But the approach that we think is the future of medicine is that's just the beginning. Then you start to do all the continuous engagement with different members of the team. It's not the doctor anymore. Think of the doctor, and I'm going to use an American analogy, as the quarterback of the football team. That's the person that reads the field, has got the ball, and sets the play. But once that ball leaves the quarterback's hand, it's in motion. Everyone on the team is running the field, trying to make the play and trying to score that touchdown. That's the approach that we should have in healthcare. And so supporting our doctors, we've got this incredible team of humans. All of those people have access to the data that you need them to have access to in order to help you make good decisions. So your lifestyle coach might be really focused on your stress scores from your Aura Ring. Your dietitian might be really focused on your food logging and your sleep scores and say, hey, the fact that you're not sleeping well is raising your cortisol levels, which raises your hunger levels, which leads you to poor food choices the following day. It's all related. And it's kind of complex if you're trying to tackle it on your own. But when you've got a great team to support you with the data, it becomes so much easier. And so that's the journey. It's this magical journey of navigating your own data in a non-stressful way, where you actually feel empowered. You feel like, wow, this is the first time in my life that I actually feel seen by my healthcare provider, but I also feel super empowered to own it myself. I don't want to rely on the doctor to give me the answer. I'm giving myself the answers. And that becomes a first step among many into, improving yourself 1% every single day. So what's the punchline? All of this, it sounds great. What is the actual punchline? Um, does it work? Fair question. And the answer is we have the world's best outcomes and we publish. I spend a couple $1 million a year on a research team. You'll never see a clinic do that. But I publish more than any other healthcare provider in the Middle East, including the biggest ones that you've all heard of. We have over 40, maybe by now 50 publications in global academic journals, including the only paper out of a private healthcare player in the Middle East in the New England Journal of Medicine. It's all on our website. If you're nerdy like me and interested in reading it, you can go and access all of it. But we are radically transparent about what we do, how we do it, and the outcomes that we generate. And that is table stakes. If you go to a hospital and they don't track and report outcomes, I wouldn't trust them. It's marketing unless it's evidence-based, right? So that's our approach. We're very, very committed to doing this, and we fund it. There's no other way. You've got to do it yourself, and you've got to take that accountability. And one of the reasons why insurance companies love us, despite the fact that we do cost more to them than some random little, medical clinic, is that every quarter I send them a full report on the overall outcomes, not your own individual outcomes, because we can't do that from a data privacy perspective, but we give them a sense of how we've changed the risk of their population for their covered members across all the employers that they work with, which no provider has ever done. And I'll close with one last point and then maybe open up for questions. There's this movement now towards what's called value-based care, which is that in the past, healthcare has been fee for service. You go to the doctor and you pay for four things. You pay for the doctor visit, the lab tests, the diagnostics, and the drugs. In the future, we should not be paying for healthcare in that way. We shouldn't be paying for things. We should only pay for the outcome. Has the doctor or the clinic or the healthcare provider helped me achieve an outcome, and pay for that? Now, we're a long way from getting there, but the building blocks are tracking, measuring, reporting, reinventing yourself, following the evidence, which most other healthcare providers simply don't do because it costs money and they're not incentivized to do it. Ultimately, we'll get to a point where our relationship with insurance companies and with employers is value-based, right? And so you pay for the outcome itself, not for the things that are done. So I'll pause there, maybe, and I know that's a lot to chew on, but hopefully it gives you a sense of things.
And I think that working obviously in the industry, and this is one thing that I work really closely with the insurers, is that educating them that yes, it may be costing them now, but it's actually saving them so much money in the long run. So we never get, the prevention side of it, the doing and getting all this information so we know we can change our lifestyle. So so then we don't have diagnosis of diabetes and cancer and all the rest of it. So that's definitely the kind of, I think you could probably agree that tool to get scanned and have that early education around things is really important.
Before I open up the questions, though, I know like a lot of what I said might be kind of scary to hear because you don't think about this stuff in sort of daily life, and you jump on a webinar with some dude and he's starting to like tell you everyone is going to become obese and diabetic. Yes, everything that I've said is true. The data does exist, and most of us will face these challenges, myself included. I went to medical school, and yet I became overweight, nearly obese, and pre-diabetic. So if it can happen to me, it can happen to you. The good news is all of these risk factors are really easy to address. And I'll tell you, you don't have to go to some, longevity clinic and pay a bunch of money to do a bunch of weird experimental esoteric things. There are 5 things that all of us can do to start bending that curve. Number one, and it might surprise you to hear this, the thing I would put as the number one priority is treat sleep like a job. I was one of those guys that would sleep 4.5 hours a night and feel macho about it because I could power through my next day, right? The hard charging, fast-paced life of an entrepreneur. It was killing me. I started wearing my Oura ring and I was tracking my sleep, and it was shocking how bad my sleep was.
I was going to say, what's your normal score?
Huh? My score was like in the 60s. It was horrible. And now I'm consistently like 80s. Sometimes I break 90.
Okay.
But I'm still not, I'm still trying to improve. So I've brought my average sleep from 4.5 hours now to about 6.5. I'm trying to get to an average of 7 hours of sleep per night. And I think that's the right sweet spot for me. But that had to happen in order for me to lose weight and keep it off. The fact that I was chronically under rested meant that it was this vicious cycle of cortisol and appetite and overeating and binge eating. And gosh, it was what was keeping me fat. So number one, treat sleep like a job, which means what? KPIs, metrics, track it, be accountable to it, treat it like a responsibility. Number two, eat whole foods, right? And it might cost more to do that. Cheap food is also tasty food, right? Good food also is tasty, but can cost more when you go to the grocery store. And I recognize that. But that is the best investment you can possibly make over the long term. Avoid things that come out of a package. Spend a little bit more time preparing your own meals. Make it a family thing. Make it a way to connect with other humans. It's built in our DNA to want to do this. Number three, walk frequently, ideally after meals. I've got an uncle who's type 2 diabetic. I put a CGM on his shoulder. It's incredible. He eats now, looks at his CGM numbers, and if he sees it starting to move, he'll get up and leave a conversation and just start walking. And it measurably brings down his blood sugar. It's incredible. Number four, lift heavy weights. And this is probably the most difficult thing for most people to grasp, understand, and act on. Lifting heavy weights doesn't have to happen in the gym, can happen at home, but doing it safely, doing it properly in a way that builds skeletal muscle mass is not easy, and it needs education. It's accessible, we can all do it, but there's a technique to do it in order to do it safely. And why do I say lift heavy weights specifically? Because if there was one drug that is most highly correlated to longevity and health span, that drug would be skeletal muscle mass. The more muscle mass you carry, the more lean mass you carry, especially into old age, that is the strongest indicator of a long and healthy lifespan. So building good, solid base as you age when you're younger is super important because we all naturally lose muscle mass as we age. So part of that is lifting heavy. Like you're going to the gym and just taking the light dumbbells and doing this a few times, wasting your time. Wasting your time. You've got to train at a level of intensity that is to the point of failure, to the point that you cannot actually physically lift the weight again. And there's a mindset there and there's a technique there. And so it helps to have a coach. And that's why we have a coach in the clinic. But some people also work with their own, private fitness coaches and so on. So that was number four. Number five is manage your stress actively. And again, how do you quantify that? It's been hard. You can feel it. Am I stressed? Do I not? I'm one of those guys that I internalize my stress. Like you'll never see me stressed. I'll never sort of feel stressed, but based on digital biomarkers, my Aura Ring gives me a sense of when my body is stressed and when it's not. And having that data has really helped me, correlate when my markers are high and what that means on a day-to-day basis. Managing stress actively, yoga, meditation, things that you all do, but with data, it becomes a lot more structured and a lot more engaging. Those five things, there's no drugs involved, there's not a lot of money involved, there's no barriers involved, no elite, velvet rope that keeps you out of it. We can all do that stuff. Before anyone takes a Mounjaro pen, before anyone goes to a longevity clinic and does some like NAD drips, it's accessible to all of us. And the great thing about the platform that we've built is that is built into our DNA of how we empower our patients to take control of their own health. I saw on commented about his own journey.
Yeah, do you want to share that?
It's
Or is he still online?
Yeah, I'm still here.
Come on,
Yeah,
take the stage.
yeah. No, I was in tech, and I went to a conference, and Ali was speaking, and he started naming those 5 things that he just named, um, that one needs to do to stay to live a healthy life. And as he's naming them, I'm like, I don't do that. I don't do that. And so I started getting a little worried, and I booked my appointment at GluCare. And like I wrote in the chat, I found out that I was pre-diabetic, borderline type 2 diabetic. And so at that point, I thought there's like 2 things that I can do: just kind of ignore it and hide it from, my wife and my loved ones, or I can tell them about it and get the support, from outside of the clinic that I need to be successful. So I didn't do Manjaro. I thought I had the willpower of an ox, and I had a very understanding wife that allowed me 2 hours a day to exercise, which I chose paddle. And I completely changed my life. I reversed my diabetes, no more fatty liver, just started making the right lifestyle choices. And I thought to myself, there's probably thousands of people like me that probably are neglecting their health or just waiting for something bad to happen. And so a couple months after, I called Ali and I pitched him my idea, that we should do something in the corporate wellness space. And I've been working now at GluCare for some time, and we've done some amazing things with the right-minded organizations. And was very excited when I spoke with Laura, and happy to be a part of this webinar.
Thank you very much for sharing that.
It's not often that an employer, when they're recruiting new team members, can tell people that one of the benefits is that we'll very likely make you live longer if you work here.
Yeah, that's a
but
good.
Look, it's a good recruitment tool, isn't it?
Yeah.
And I have access to doctors all the time, so I ask them everybody questions. But when I started, because I didn't come from healthcare, I asked Ali about anything I could read or any podcasts or anything. And so he told me about this book, Longevity, by Dr. Peter Attia. And in that book, he
the
had
book is called Outlive.
Outlive, yeah. And so he had a reference in that book where he said Noah didn't start building the ark when it was raining. And so it really made me think, like, to be prepared for, what could happen, you have to start, doing the work now. And so a lot of the times I struggled mentally and I think I used to even WhatsApp Ali late at night and be like, the scale is not moving for the last 2 weeks or 3 weeks. So it was a bit of a struggle, but I think I learned quite a lot doing it myself, and I'm able to then communicate and share that experience with the other people that I meet that are starting their journey.
That's wonderful. Thank you. And well done. Congratulations on all your hard work.
Thank you.
Great. Any questions from the group that I can help answer? I don't know if there's a way to somebody raise hands. You could just unmute yourself, guys.
Yeah, they can unmute or they can pop it in the chat box, whatever suits you. Give them a minute.
Don't be shy.
I know, right? They'll probably get off the call and then have a million questions to ask.
Yeah.
Sorry, if my family has a history of diabetes, should I get checked even though I feel like I don't have any symptoms?
Even if your family doesn't have a history of diabetes, it's good practice to go and do an annual health check. But given that your family has a history, absolutely. Yeah, 100%.
Thank you.
From what age do you recommend, obviously there's children and, preteens and teenagers, from what age do you recommend having, even having the slightest test in regards to I guess it affects every age. So as a parent, what would you suggest?
Yeah, I'm glad you asked that because I should have touched on this. We also have a pediatric endocrinology service.
Okay.
There is a shocking degree of childhood obesity now in our community, and so we see kids, all the time that they come in because their parents are worried about how much weight they're carrying out around, rightfully so. So we do have an active pediatric practice, and if anyone here has a child and you have concerns about their metabolic health, absolutely get them checked out. I take my kids in once a year to take their blood, and the first time was hard because they were afraid of the needle, but once it happened, they're like, "Oh, Dad, that didn't hurt as much as I thought it would." So I take my kids in once a year to run their full bloods. That led to considering one of my kids for human growth hormone replacement therapy. He was on the shorter side of his peers, and we sat with our pediatric endocrinologist and elected ultimately not to do it and watch and see how he grew. But yeah, there's a lot of things that you can find that you can easily manage when kids are young. It becomes very hard if a kid who's overweight when they're younger, when they become adults, you've saddled them with that burden for life, because it changes your epigenetics. It changes in a fundamental way the way that your body expresses your DNA, and later on in life, it becomes so much harder to kind of get healthy and remain healthy if you've had an unhealthy childhood. But for adults, I think I would say anybody, any adult should at least annually do a basic blood panel, check your thyroid levels, check your liver enzymes, do a body composition analysis to see just how much fat mass you're carrying around, just how much muscle mass you have. That's just good practice, and it's generally covered by every insurance company. So there's no reason not to do it. Yeah, but if you've got risk factors, if anyone in your family has ever had a heart attack, if anyone's ever had a stent put in, if anyone's ever had prediabetes or diabetes, absolutely you should go in. I think someone's raised their hand. Amar?
Yeah. Hello. The informations you gave were pretty good. Just a quick question. I am pretty active in my life. There has been no family history in life as well for diabetes. But I can't do weights, as you mentioned, weights in terms of hitting the gym and all, because I have some nerve condition. But I do a lot of cycling, like probably like 30 kilometers, 40 kilometers a day. My what are like what else can I do to keep this in control? Because I love sugar, and I eat a lot of sugar. I consume in ways like energy drinks and stuff. So what would you suggest for me?
Yeah, look, it's hard to manage those limitations. I lived through that, so when my health took a downturn, it's because I had, an ACL reconstruction of my knee, which is a major surgery, a shoulder reconstruction here. So for almost a year and a half, my upper body and my lower body were out of commission. And I gained a lot of weight because my appetite didn't change. I was still eating the same stuff I was eating before, and I wasn't exercising. So it's great that you're mindful of that and aware of that. There's a lot you can do that doesn't necessarily involve weightlifting. Yoga, Pilates, and body weight calisthenics, if you're able to do those things, can be extremely effective at getting you the degree of exertion that you need to maintain muscle mass and your metabolism. So there are other ways. You don't necessarily have to go to a weightlifting gym to do these things. But you need guidance. It's hard to figure this stuff out on your own, honestly. With respect to the appetite and the sugar, and I didn't touch on this, but the food industry is also one of our biggest enemies. It's very profitable to make cheap food. It's very profitable to make sugary food. It's sticky. People love it. People consume it. It's the reason why they exist, because they sell, and they sell because it tastes good and it's addictive. What all of us are fighting is dopamine. Dopamine is a neurotransmitter in your brain. Think of it like it's the neurotransmitter that gets released when you win the lottery, okay? Or actually when you're gambling in order to win the lottery, right? It's that anticipation hormone, neurotransmitter. And that is directly involved in our appetite circuitry. It's why appetite and gambling and smoking are all related. It's why when people are on Ozempic and they say, my appetite has disappeared, those same people will stop drinking, will stop smoking, and will stop obsessive compulsive behavior. It's amazing what effect these medications have on that neuro circuit that we've got. I felt that when I was on Ozempic, food noise disappeared. Like I was a guy, I love food. I love sweets. My sister-in-law, if you follow her on Instagram, her Instagram is Cooking with Zahra. And that food that you see on her Instagram is always in our house. Okay. And so I would just constantly be eating. And it's good food too. It's wholesome. Like I'm someone who doesn't eat fast food ever. I don't eat packaged food. I eat whole foods. So that, that second or third thing, eat whole foods. I just eat a lot of it all the time, and I was snacking and eating late and a lot of it had sugar in it, right? And that's hard. That's hard to manage if you've got that sweet tooth, because you got to break that dopamine circuit. It's the dopamine that's pushing you to do that. You don't need sugary energy drinks. You need water. Okay. Energy drinks, you don't need it. It's marketing. It tastes good. It looks good. It's convenient. Comes in a bottle. It's cold. It's refreshing. It hits all the things that make your brain light up and say, wow, I love this. But you don't need it. Right. And there's a lot of things that we put in our mouths that we just don't need, but it feels good. And breaking that takes deliberate effort. And so our dietitians and our nutritionists really help our patients figure that out and navigate it. When I was on Ozempic, it made it easy, honestly. Like all the food noise just gone. I would find myself at the end of the day realizing I hadn't eaten breakfast or lunch and I wasn't hungry and I wasn't even thinking about food. I wasn't even bothered. So I would start eating food deliberately because I knew my body needed the nutrition. It really changed my relationship with food, right? But once you come off the medication, the appetite comes back. And so you need to spend enough time going through that journey to structurally change your habits so that they become long-term lifetime habits.
Yeah,
Thank you so much.
Yeah.
Can I add to it just one quick question? Is obesity 100% related to diabetes? Like I'm not obese at all. My BMI is perfect. Is there a risk? Like I hope you understand what I'm trying to ask.
Yeah. The bad news for you, because you're of South Asian descent, is that genetically, South Asian populations, myself as an Iranian, and people in the Gulf, but much more so people of South Asian descent, they are genetically more susceptible to becoming pre-diabetic and diabetic when not obese. So, I'll give you an example. One of my friends, he's Pakistani. He's very educated, Cambridge educated lawyer, called me up and he's like, hey, Ali, I'd like to come into your clinic. I'm type 2 diabetic. And I was like, dude, what do you mean? What are you doing about it? At first I said, when were you diagnosed? He says, about a year and a half ago, 18 months ago. So some hospital told him casually, oh, by the way, you're type 2 diabetic. And then didn't tell him what to do about it. So he'd been living with full-blown type 2 diabetes for a year and a half, hadn't done anything about it. And he was not fat. He was skinny fat, I call it. So he had very little muscle mass because I don't think he's ever lifted a weight in his life. There's too much in his books. But he was carrying around a little bit of extra visceral body fat in his abdomen. He's carrying a little, and but by no means would you say that this guy was even overweight. And so if you look at the data, you could have two people come into the clinic. One, a South Asian individual who's carrying around a few extra kilos of visceral body fat. This is the fat that's around your organs, inside your body. So it's not fat that you can grab onto. These are not love handles. This is inside, okay? And so it's hidden pretty well. You can take someone with a little extra visceral body fat who's South Asian, they will be full-blown type 2 diabetic or pre-diabetic. Very common. You could have a Caucasian person, a white guy from the UK or Minnesota, and I met one yesterday, actually. He came to my house. He was a, this happens to me a lot. Like I'll just have conversations with people. This guy was heavy. He came to my house. He's a technician. And I was like, dude, when was the last time you got yourself checked? It's a little bit of an awkward conversation at first because he was heavy. And he's like, yeah, funny you should ask. I just did a blood panel. I said, and everything's okay? He's like, yeah, metabolically, I'm okay. So you can have a very big human who is Caucasian, and their bodies somehow don't appear metabolically dysfunctional, even though they're carrying a lot of extra weight around. So your original question, and sorry, this is a long answer to a short question, but it's an important one. Obesity is a strong risk factor for the progression towards prediabetes and diabetes. 100%, very strong. So if someone is obese, it massively increases the risk for all kinds of diseases, cancer, diabetes, cardiovascular disease, everything. Obesity is central to so many diseases. But it doesn't mean that if you're not obese, you're not going to become diabetic. And that's where genetics come into play in certain populations.
Thank you.
Thank you so much.
I did see somebody else with their hand up. Did anybody else have any questions?
Hi, guys.
Hey.
Hi.
There are some questions
great.
on the chat.
Sorry. Great presentation, Ali. Really informative stuff. I had a question around, there was a study that was carried out not that long ago about the reversal of type 2 diabetes. What I would be interested to know is from your patients that have come to you via GluHealth, what is the data showing that people who are diagnosed with type 2 that have then reversed their disease? Because that was new to me. I didn't know if that's something that was commonly known. I'm pretty sure there was like a recent study a couple of years ago that proved that having a low calorie diet does reverse type 2 diabetes once you have the disease. I just wanted to know what your experience was with the data from your clinic.
No, great question. Let me add a little color to the world of clinical studies, because not all studies are created equal. And so when you read studies that are put out there, you always have to look at the source of the study, who did it, what the study design was, and where it's been published. If you have that study, I'd love for you to send it to me so I can read it. I've read a lot of similar studies. Some of that ends up becoming self-promotional work that people put out for a particular product or service. The reason I am suspicious about this study that you're mentioning is that the language that they're using is language that we wouldn't use. We try not to give anyone the expectation that diabetes can be reversed. It's like cancer.
Right.
Once you've had cancer, you can beat it and you can put the cancer into remission, right? But the risk, that underlying risk is there, because
Right.
that's a genetic risk and it's a lifetime risk. We can eliminate the disease, or at least the presentation of it. But someone who's had cancer for the rest of their life is going to do more frequent testing and screening to make sure that that cancer never comes back. Does that make sense?
Right. Yes.
It's the same with diabetes. So the language that we use is remission.
Right.
We are very good at pushing diabetes into remission, but we try never to say that we're going to reverse your disease, because the underlying risk that got you there is still there. And you've got to then manage it to make sure it stays in remission. So when people talk about, hey, we can reverse diabetes, I find that to be a little bit irresponsible, because it's not It's not clinically sound language to use. Now, I know it might feel like I'm, threading the needle a little here, but I think language is important. That said, there's a lot of data out there on different ways that you can manage. Let's call it risk management. Let's not call it reversal or remission, because whatever language we use, what you're actually doing is risk management, right? So if you reverse or push diabetes into remission, you're drastically reducing the risk profile. So it's actually all about risk. And yeah, you can bring risk down massively. So I'll give you a couple of examples on our own data. I can't comment on other people's data, but I'll tell you about what we've published. So we take populations of our patients, and we do often retrospective studies on these, and we publish that. So if we look at our pre-diabetic population, so people who have come into the clinic not knowing that they were pre-diabetic, they get diagnosed. Okay, how do we do in managing those patients? On our pre-diabetic population, we have a 81% success rate in pre-diabetes is something that we're comfortable saying reverse, okay? So we have an 81% success rate in reversing pre-diabetes in 3 months, which is among the best outcomes in the world, okay? And pre-diabetes, I think, it's easier to keep it in remission because the underlying risk delta that you're dealing with is much different than the diabetic risk delta. In the case of diabetics, we did a really interesting study recently where we took diabetics who were already being managed by other clinics. These are not people who are lost in the system who didn't know they were diabetic and so on and so forth. These are people who are going to Imperial in Abu Dhabi or going to Mediclinic. They're already taking Mounjaro. They're already on the best medications. These are people who are actively managed. This will shock you. If you look at Imperial College London Diabetes Center in Abu Dhabi, huge, they manage 100,000 diabetics. My co-founder, Dr. Ihsan, built it when he was the deputy head of healthcare at Mubadala. It is still old school healthcare. After 10 years, if you look at their latest published outcomes, 75% of their patients were still considered poorly controlled, meaning their hemoglobin A1C was over 7. Maybe some of you guys don't know what that is. Hemoglobin A1C is a very simple blood test and that's part of a diabetes screening, where it's basically what is your average blood sugar for the last 3 months. So think of it like the concentration of blood sugar, right? Think of like a cup with a bunch of sugar in it. What's the percentage of sugar in the blood? That's an easy way to think about it. So someone with a hemoglobin A1C of below 5.7% is considered metabolically normal. Between 5.7% and 6.5% HbA1c, you are now in the pre-diabetes range. Above 6.5%, you are in the diabetes range. Above 7%, you are a poorly controlled diabetic. What does that mean? That puts you into the highest risk category. When you're poorly controlled over a long period of time, that's when you get liver damage, kidney damage, brain damage, cardiovascular damage. That's when all of the gnarly, hairy, bad side effects of diabetes happen, when you're chronically out of control. Okay, so it's really important when we think about diabetes reversal or diabetes remission, it's really important to bring diabetics down below the poorly controlled level. And in Abu Dhabi, at Imperial, after 10 years, most of their patients are still poorly controlled, despite having access to all the best drugs, all the best docs, and so on, which is shocking. So we did a study where we took these patients, brought them into GluCare, put them onto our structured program. We had 100% success rate in bringing those poorly controlled diabetics into the well-controlled range in 1 year, which is unheard of. Again, these are patients that are already taking Mounjaro and Ozempic and all the other meds. And on top of that, in addition to succeeding in bringing these patients under control, we also, on average, reduced all of their medications. So we took them off blood pressure drugs in some cases, Ozempic in some cases. We actually took people off of a significant amount of their pharmacological load.
That's
Right?
amazing.
Yeah,
That's very
and these studies are
cool.
all on our website. You guys can go and read them if you're curious.
Thanks,
Definitely,
Ali.
definitely.
Appreciate it. Thank you.
Yeah.
I have 3 questions in the chat box, so I'll glide over them. So obviously on this call we have many different levels of cover. Are they happy and pretty much is it okay if they just contact the clinic directly and you can have a look into their insurance and you can see what kind of coverage they'll have, or what's the best way to go about it?
Yeah, you could just WhatsApp the team.
Yep,
They're pretty
perfect.
responsive. The clinic is getting pretty busy these days, so I would avoid weekends and Fridays.
Okay.
But yeah, just WhatsApp the team. Our call center staff have all the tools to check your eligibility. You'll send them your Emirates ID. They'll check whether you're networked. They'll tell you what your copays are. Generally, most of the other insurance companies are pretty good. And yeah, so if you haven't done a blood test in a while, you haven't come in a while, you'll come in and just sort of do the basic screening package. It'll take about an hour to an hour and a half in total. You'll do the blood test, you'll do all the AI-powered diagnostics and the ultrasounds and so on. It's all included fully in one visit. And you'll see a doctor and you'll go through all those results. And that's the start. Based on whatever those results show, you'll then enroll in a diabetes management program or a pre-diabetes program or a weight management program. The diabetes and pre-diabetes programs, the hormonal programs, these are all generally covered under insurance. Unfortunately, because obesity is not considered a disease in the UAE, obesity treatment programs are not covered under insurance. So if someone is only managing their weight, and we encourage people to do so because it's a major risk factor and it should be covered, it's not. And so that's the main thing that's out of network, and people generally pay cash for that. Other things that people pay cash for that I haven't talked about, which is still part of the work that we do, is all the broader endocrinology hormonal stuff. So testosterone replacement therapy program, it's very common. Men, as we age, it's totally normal and totally natural that our testosterone levels drop. And so TRT, testosterone replacement therapy, is a very popular program that we have that is usually a cash out-of-pocket program. For women, we have a full women's health program dealing with perimenopause and menopause. And so we have a very strong approach to hormone replacement therapy, estrogen and testosterone for women. You'd be surprised. Yes, women do take testosterone. And so all of these things are part of that baseline. And you can ask the doctor any questions about any of this stuff.
That's wonderful. Thank you. How can a person with type 1 diabetes effectively manage their blood sugar levels using an insulin injector instead of an insulin pump?
Sorry, the question is, how can they do that?
Yeah.
Yeah, I mean, that's historically how all type 1s would manage. They would manage with injections. Pumps were invented to decrease the burden. And pumps are life-changing. They're very expensive, but they're life-changing. And most of our type 1 diabetics are on pumps. Also glad that someone asked this question because I didn't talk about type 1. We have a very active type 1 practice. We have a very special relationship with Medtronic because of the work that we do and the outcomes that we generate. If patients are eligible, we can sometimes, actually often, get Medtronic to give them the pump for free. We have a special program. It's a research program. And this is, I don't know exactly the cost, but this is like a 40,000 dirham expense. So through our program, we can sometimes get a lot of these really expensive things covered for our patients, working with the pump companies. But yeah, pumps are fantastic. We introduced Insulet to the market. We were the first to bring them in. And we help our type 1 diabetics manage their disease very effectively. There's another study that we did. We were the second clinic in the world to do this, where we put type 1 diabetics on Ozempic. And the results were incredible. We were able to reduce their overall insulin needs by 25%. And so this is what I call, this is what's called off-label use of drugs. So Ozempic, at the time that we did this study, was only approved by the FDA for diabetes management, for type 2 diabetes. It wasn't yet approved for weight loss. We were using it off-label for medicated weight loss. We also used it off-label for this application on type 1 diabetics. So because we're a research-oriented medical practice, we can take medications that have strong clinical evidence, but not FDA approval, and use it in ways that help our patients.
So most of the attendees on the call have screen-based sitting jobs. Does this increase their risk of diabetes? And what do you recommend for long sitters, especially during those working hours?
Very good question. And I think that applies to all of us, myself included.
Yeah.
I bought a walking pad and stuck it under my desk. So I'm doing this call with you guys today from home. But if I was at the office, you'd see my head bobbing back and forth because I'd probably be walking on my walking pad. And that's a very easy and cost-effective way to change habits. Put your laptop on an elevated stand, get yourself a electronic walking pad. They're not that expensive. A few hundred dirhams, maybe 600-700 dirhams, you can get one. And just walk a lot while you're on calls and while you're doing meetings. Make that habit. That's something that I started doing earlier this year. So that's something I would strongly recommend. Otherwise, always, build it into your schedule to take regular breaks. It's not just about metabolic health. It's also about musculoskeletal health. Posture, all of us are horribly postured these days because of the amount of time that we spend on our screens and on our phones.
Yeah, very, very true. We all need to sit up straight. Wonderful. Well, I think that's all the questions, but thank you so much for today's session. Extremely educational. Wonderful, again, for everybody to be able to have any questions that they have. If they do have any more, I'll be sure to reach out to yourself, but thank you very much for today.
Yeah, thanks, guys. Happy to have this chat with you. Any other questions, feel free to reach out. Our team is also super helpful. You can WhatsApp them, and they're pretty responsive.
Amazing. Well, thank you very much. And have a lovely day ahead. Thank you, everybody.
Thanks.